Dr. Chauhan. Thank you, BFI, for giving me a chance to moderate the session where the speaker is none other than a person from my own institution and son of my two great teachers. I have a great regard for both of them, and I love the association I had with Rohtak Medical College. So, most of the institutions which have been specialized, like escorts, was only for heart. So they are also now diversifying. They have included many other specialties. Likewise, the Indian Spinal Injury also is no more now a spinal injury center. It's opening up for other specialties like cardiology. And the present director and head of the cardiology at Indian Spinal Injury Center, Vasant Kunj, or we can say the spine of the spinal injury cardiology, is none other than my great friend Dr. Aseem Dhall. So he did his MBBS and MD from Rohtak Medical College, his DM from KG Medical College, Lucknow. He has numerous publications which appeared in various journals of national and international repute. But basically, he is a very upcoming, laborious, quite as Dr. Chauhan has said, not making noise about his work. And we will hear from him on the topic of stroke prevention in non-valvular AF. So this topic, I think, is just equivalent to Sundarkand of Ramayana. We have heard so many times and we will hear so many times. Every time we learn something new with a new person presenting the forum, with his own ideas, with his own in his own language. So Vasant Kunj के जो cardiology department की जो spine है, Dr. Aseem Dhall, he will now apprise us about the stroke management in non-valvular AF. So over to Dr. Aseem Dhall. I'll request to make the talk may not be too lengthy. Spare more time for interaction. We have very, you can say, active, reactive oxygen species here in our group who react more, and they rather share knowledge both ways, not only one way. We all get benefited from their knowledge, their experience. So, you know, I'm pointing to my stalwarts in my group. Sir, all to you.
Thanks, sir. Thank you very much for the nice words. Let me first thank Dr. Chauhan for inviting me to this podium for under the banner of Physician Forum of India. And thanks to you, Dr. Kalra, who has spoken such nice words about me. So the topic of today's discussion is stroke prevention in non-valvular atrial fibrillation. I'll be briefing myself on the practical aspects on the use of NOACS. So what are NOACS? NOACS have been named as novel oral anticoagulants. Some people say newer oral anticoagulants. Some say as non-vitamin K antagonist oral anticoagulants. And some are known as DOACs, which means the direct oral anticoagulants. And what is non-valvular atrial fibrillation? So in various trials of NOACS, it was found that the atrial fibrillation patients of various etiologies were included, except for moderate to severe mitral stenosis and patients who were having prosthetic mitral valves. So these two categories of patients were excluded, and rest all categories of different etiologies of atrial fibrillation were included. So atrial fibrillation is an important risk factor for cardioembolic stroke, and non-valvular atrial fibrillation is associated with 5-fold increase in the risk of stroke. And the prevalence of atrial fibrillation in our country or in Indian population is around 0.6%. So before we start discussing further, there are certain important scores which need to be looked into. One is CHADS 2 risk score, the other is CHADS 2 vascular risk. The CHADS 2 risk score included patients, the C for CHF, H for hypertension, A for age more than 75, D for diabetes, S for stroke or TIA. And depending upon the presence of one or two risk factors, they have been scored at different things. But the problem with this score was that even when the CHADS2 risk score was 0, the annual incidence of stroke was 1.9%. So the people thought, who were doing the trials, they thought that they had to add something more to make it more informative. So they came out with another score, which was CHADS2 vascular risk score. And all the factors of CHADS2 score were the same, and this included VASC risk as an additional factor, which included vascular risk in the form of a coronary artery disease, peripheral vascular disease, or accelerated atherosclerosis at any other point. Plus, it included two more factors, which was age between 65 and 75 years of age and female sex. So, depending upon all presence of one or more factors, the CHADS2 vascular risk scoring is done. And this gives an indicator of the risk of stroke in such patients. The third risk scoring is a bleeding risk score, which is the Hasbled score. So H again for hypertension, A for abnormal renal or hepatic function, S for stroke, B for bleeding history or anemia, L for labile INR, E for elderly, and D for different drugs. And depending upon that, again, the risk scoring has been done. So if a person has 0 to 1 score, he's included in low risk, and if he has more than or equal to 4, then he comes into a high risk category for bleeding in such patients who have to be given NOACS. So what are the advantages of NOACS? The NOACS have rapid onset of action, and because of their rapid onset of action, there is no need for bridging of heparin therapy in the intervening period. Second, it has a predictable anticoagulant effect, so there is no need for routine coagulation monitoring in such patients. The NOACS target specific coagulation enzymes and thereby causing low risk of off-target adverse effects. And then NOACS, they have low potential for food interactions and drug interactions. So as this is all in comparison to vitamin K antagonists, non-vitamin K antagonists. So and the dietary restrictions and there are fewer drug restrictions as compared to the other category of drugs which are used. So these are the 4 NOACS, the dabigatran, apixaban, endoxaban, and rivaroxaban, which are available. So out of these, 3 are available in our country, dabigatran, apixaban, and rivaroxaban. And these 3 are approved for various uses for stroke prevention in atrial fibrillation in our country. And the most important trial for dabigatran was RELY trial, apixaban Aristotle trial, rivaroxaban Rocket AF trial. And the doses which are used to prevent stroke in these patients of non-valvular atrial fibrillation, the dabigatran was used in a dose of 150 milligram twice daily traditionally, apixaban 5 milligram twice daily, and rivaroxaban 20 milligram once daily. So the prediction of stroke and bleeding risk, and as we have just studied that CHADS2 vascular risk score is recommended for stroke risk prediction in these patients, and the bleeding risk scores are also important to streamline the therapy of novel oral, newer oral anticoagulants. So what are the risk factors for for bleeding or in these patients? There are modifiable bleeding risk factors, there are potentially modifiable risk factors, there are non-modifiable risk factors, and there are biomarker risk factors. So the modifiable risk factors are hypertension, labile INR, drugs, and excess of alcohol. The potentially modifiable being anemia, impaired renal function, impaired liver function, and reduced platelet count. While the non-modifiable risk factors are the conventional risk factors like age, elderly patients, history of stroke or major bleeding, chronic liver disease, malignancy, and genetics. And the biochemical, biomarker-based bleeding risk factors are high sensitivity troponin, serum creatinine levels, renal functions, and all that. So this was a meta-analysis of different NOAC trials versus warfarin for stroke prevention of in these patients of atrial fibrillation, and it was found that in all these trials, NOACs fared much better as compared to warfarin, and the trials suggested NOACs over warfarin in all these patients in stroke prevention. And this was a safety analysis of NOACs with warfarin for stroke prevention. And again, NOACs scored at all levels over warfarin in these patients. And so the oral anticoagulation, what do the oral anticoagulation guidelines for 2020 say? The oral anticoagulation guidelines say that these therapies are recommended for all patients, male patients with atrial fibrillation with a CHADS-VASc score of 2 or more, and this is class 1 indication. And this is indicated in all female atrial fibrillation patients with a CHADS-VASc score of 3 or more. While in patients, male patients with a CHADS-VASc score of more than 1 and female more than 2, they come under class 2A indications. So if you have a score of 2 or more or 3 or more, then these are the agents which are to be used. And in patients when oral anticoagulation is needed in atrial fibrillation patients, then a NOAC is always preferable as compared to a vitamin K antagonist or warfarin. And most importantly, there is no role of antiplatelet monotherapy in such patients for stroke prevention, regardless of the risk of stroke. And NOACs, as I told, are not recommended in patients of moderate to severe mitral stenosis and mechanical heart valves, because these form the exclusion criteria in all the trials of NOACs. So again, the stroke prevention after exclusion of mechanical heart valves and moderate to severe mitral stenosis, then you do the risk assessment of CHADS-VASc risk. If again the CHADS-VASc risk is more than 2 or equal to 2, then oral anticoagulants are required. And if it is 1, then you may consider it depending upon the other additional risk factors and the bleeding risk factors calculated by Hasbled score. So we'll go into the details of in different case scenarios. We'll take up one by one the use of NOACs in chronic kidney disease patients, in elderly patients, patients who have GI bleed, patients who are having valvular heart disease, patients who have bleeding complications, patients who have recent history of stroke, patients who present with acute stroke while on NOACs, and patients who are having coronary artery disease and need a coronary angiography or angioplasty on NOACs. So depending upon these, we'll go one by one because these are the practical things which will help you in choosing the type of NOAC in different scenarios. So as far as the renal function goes, the most important thing to understand is that dabigatran is the one which has most renal excretion to the tune of 18%. Apixaban is the one which has least renal excretion to the tune of 20-25%. And rivaroxaban is in between the two. So in patients who have more creatinine clearance more than 30 or 50 ml per minute, you can choose any of these. But in patients who have creatinine clearance who is having less than 30 ml per minute creatinine clearance, then the best drug in renal impairment patients would be apixaban, and the doses would be 5 milligrams twice daily. However, in patients in which the Hasbled score is found to be more, in which the age is more than 80, the weight is less than 60, or serum creatinine levels are more than 1.5, in such cases, the doses have to be reduced to 2.5 milligrams twice daily. And dabigatran should not be used in patients with creatinine clearance less than 30 ml per minute. And this is the efficacy of apixaban in Aristotle trial, which showed that at different levels of EGFR, the drug was well tolerated and was better as compared to warfarin, with lower risk of bleeding as compared to warfarin. And this was again to test the efficacy of different NOACs in patients with or without renal impairment. And it was found that if you have to use dabigatran in such patients, then dabigatran doses have to be reduced to 110 milligram twice daily. Now, dabigatran is a very potent drug for prevention of stroke in such patients. But in renal patients, because of the extensive renal excretion, the dabigatran dose, if you have to use it, you have to reduce it to 110 milligram twice daily, in contrast, instead of 150 milligram twice daily. So that would further decrease the deterioration of the renal function and also decrease the bleeding tendencies in such patients. And apixaban is always beneficial in reducing the stroke and major bleeding and was found to be much better than other agents. And this is a comparison of different NOACs according to the age. So if we see in elderly patients, which NOAC is best to be used? In elderly patients beyond 75 years of age, these patients have multiple comorbidities, these patients have risk of bleeding, and apixaban again has an edge over other agents. However, dabigatran and rivaroxaban are also good agents in such, but the doses of these agents have to be reduced again. The dabigatran has to be reduced to 110 milligram, rivaroxaban has to be reduced to 10 milligram instead of 20 milligram dose. And again, the risk of major bleeding from different NOAC trials. So the major GI bleed is the one which is the most important in such patients. And again, the apixaban patients who are having GI bleeding or are more prone for GI bleeding, and you must have to use some sort of NOAC because of some reason, then the apixaban is the one which has scored better over these. So in patients of high-risk GI bleed, either vitamin K antagonist or another NOAC other than dabigatran, rivaroxaban, edoxaban can be used, which is apixaban. So coming on to another important topic, what do you do when a patient comes with acute ischemic stroke in an emergency department, or to you in OPD? So in acute ischemic stroke, as in coronary artery disease, we need to thrombolize the patients. And if the patients are taking NOACs, then it is extremely difficult for a patient to have thrombolysis. So the guidelines say that if the NOACs are not being taken, if a patient has not taken NOACs in the last 48 hours, then you can proceed on to thrombolysis in such patients. However, if patient has taken NOACs in 24 to 48 hours period and there is normal renal function, then you must see the plasma levels of these drugs. And if the plasma levels of these drugs are less than 30 nanogram per ml, then again you can consider thrombolysis in such patients. And if a patient has taken NOAC within 24 hours, then you just can't thrombolize such patients and you have to treat the patient conservatively with other means, or you can go in for endovascular thrombectomy. So what happens if a patient is having ischemic stroke? He is having TIA or a stroke with a neurological deficit, and you want to start NOACs in such patients. Initially, of course, you stop NOACs, and then when these patients have TIA, or then you have to restart NOAC in such patients. So in TIA, it is recommended that you should wait for more than 1 day or equal to 1 day to start the NOAC. In patient who has got stroke and mild neurological deficit, you can think of restarting the NOAC after 3 days of the stroke onset. In patients who have moderate neurological deficit, you must wait for a week or so to start the NOACs. And in severe neurological deficit, then you have to wait for at least 2 weeks. But it is always recommended that other risk factors need to be studied. Then the serial CT scans need to be done to assess whether there's hemorrhagic conversion of the infarct or not on the ongoing therapies. If there's no hemorrhagic conversion, if the patient is not a very elderly patient, if the other risk factors are fairly controlled, or there's no uncontrolled hypertension, and the patient does not require a dual antiplatelet therapy, which means that he does not have things to have to add on to more bleeding risk, then you should try to wait for a period of 4 to 8 weeks, depending upon the situation what the patient has. So suppose a patient now is on NOAC and has bleeding. So how do you go about that? So then you have to see whether a patient has mild bleeding, or he has a major bleeding which is non-life threatening, or he has a threatening life bleed. So in case of minor bleeding, generally the minor bleeds subside by their own, because these NOACs have a plasma half-life of around 12 hours. So if you stop NOACs for 24 to 48 hours, those bleeding tendencies tend to stop, and and then you can add, in case it doesn't stop, then you can add certain other measures to stop the bleeding. And if it is a major bleed which is non-life threatening, again you have to stop NOAC, and you have to resort to additional measures, like if it's a GI bleed, you have to do endoscopy and do the endoscopic cauterization of these, or you have to replace fluids or TRBCs or platelet substitutes and so on. But if it is a life-threatening bleeding, if a patient has a life-threatening bleeding, then you don't have a choice but to not only you have to stop obviously the NOAC, but then you have to give the antidotes to these drugs. So the antidotes which are available for dabigatran comes by the name of idarucizumab, which is given in 2 doses of 2.5 gram IV over 10 minutes. And for other 3 categories of drugs, this is andexanet alpha, which is to be given, because short of that, then if it is a life-threatening bleeding, because time is extremely important in such, so when you give these drugs, after 10 minutes, these drugs start acting and they revert the levels of NOACs and they control the bleeding. And besides these, other conservative measures have to be taken into account, like fresh frozen plasma or platelet concentrates or coagulation factor concentrates. All these have to be given. And this is again the same thing which another expert committee of 2017 has said, that the different ways to control and manage bleeding. So coming on to the other important topic, in coronary artery disease patients, what do you do in such patients when they have atrial fibrillation and require the addition of NOACs? Because these patients are already taking antiplatelets, ecospin, clopidogrel, ticagrelor, all these are adding, and NOAC add to the bleeding risk. So coronary artery disease and atrial fibrillation have an overlap. 1/3 of atrial fibrillation patients have history of coronary artery disease, and coronary artery disease patients do have atrial fibrillation at some point of time. So it is extremely important that the risk of thrombosis, the risk of stroke, and major bleeding, they have all to be taken into account. The stent thrombosis is prevented by addition of dual antiplatelet therapy, and the stroke is prevented by oral anticoagulation therapy, and both these cause bleeding in such patients. So a balance needs to be achieved, that the patient does not have stent thrombosis and also the stroke is prevented, and at the same time there are chances of bleeding are also minimized. So now if an atrial fibrillation patient is on NOAC and he comes to us with either acute coronary syndrome, or we need to do coronary angiography or angioplasty. So how do we go about it? If a patient of acute coronary syndromes are divided into either ST elevation MI or non-ST elevation MI. So if it is ST elevation MI, then you stop the NOAC, you load the patient with aspirin and clopidogrel or ticagrelor depending upon the situation, and you can proceed with primary PCI. Primary PCI is always preferred as compared to fibrinolysis in these category of patients who are on NOACS, whatever time they come in with. And if you have to do primary PCI, the radial route is much better. And the drugs which you have to, conjunct drugs which you have to use during angioplasty, they have to be minimized, like low molecular weight heparin, bevalodine, or GB2B3A inhibitors. They have to be given in half the doses as compared to the conventional this thing. And if a patient has non-ST elevation MI, then if a patient is having urgent need to do primary PCI, then we go in for urgent need to do a PCI. If it's not controlled by medical therapy, then we proceed just as the STEMI, or in case we can postpone this coronary angiography or angioplasty, then we could do it on a conservative basis, and after 48 hours, when the drug effect weans off, we can do the procedure. And if it is elective PCI and the patient has taken, then we stop the dose, and the last dose, if it is taken more than 24 hours, then we can consider the alternatives, and subsequently after 24 hours, we can go in for all sorts of procedures. Now, in atrial fibrillation patient, what is the need for, what are the protocols for starting the oral anticoagulation after acute coronary syndrome? So different guidelines have given different different opinions, but the earlier 2016 guidelines said that the triple therapy, if the bleeding they saw that the bleeding risk is low or bleeding risk is high. If the bleeding risk is low, then the triple therapy in such patients are given for a period of 6 months, and subsequently dual therapy is given after 6 months to 1 year, and beyond 1 year only oral anticoagulant therapy is to be given. However, if the risk of bleeding is high, then you have to shorten the level of triple therapy, and you just give it for a period of 1 month, followed by dual therapy for 12 months, and after that oral anticoagulant only subsequently in such patients who have undergone PCI after an ACS. And in elective stenting, if the risk of bleeding is low, then triple therapy is again given for 1 month, and after that again for 12 months the dual therapy, and beyond that beyond 12 months single oral anticoagulant is to be given. And if the bleeding risk is high, then again for 1 month you give triple therapy, you shorten the duration of dual therapy to 6 months, and then beyond 6 months you can continue with the oral anticoagulant. However, the recent guidelines have gone a step ahead in such patients who undergo elective PCI in patients or acute coronary syndrome patients with atrial fibrillation. So what they say now is that you continue triple therapy for a period of just 1 week in such patients in elective PCI, and for a period of 1 month in acute coronary syndrome, because acute coronary syndromes have more tendency for thrombotic thrombotic complications. So 1 month period is given instead of a 1 week period which is given for elective PCI. And beyond these designated periods, you give dual therapy for 6 months, and after 6 months you can continue with a single monotherapy of oral anticoagulants. So these are various PCI trials in NOACS. The rivaroxaban was Pioneer AF, dabigatran was dual PCI, and apixaban was Augustus trial. So the Augustus trial was the most important of these trials in acute coronary syndrome patients, which utilized apixaban in such patients. And it was found they had categorized into 4 groups. One group took apixaban plus aspirin plus clopidogrel. The second group took apixaban plus placebo plus clopidogrel. The third group took warfarin plus clopidogrel or aspirin plus clopidogrel. And the fourth group took a VK antagonist, a placebo, and a clopidogrel. And the conclusions were that compared to the vitamin K antagonist regimens, which included vitamin K plus clopidogrel with or without aspirin. The apixaban or the agents, the apixaban regimens, which included oral anticoagulant plus clopidogrel with or without aspirin, there was significantly less bleeding and fewer hospitalizations with similar incidences of ischemic events. And compared to no aspirin regimens, the patients performed much better with newer and newer the patients who were taking anticoagulants, they performed much better as compared to vitamin K antagonists. So another important thing is what do we do when a patient has to undergo surgery and has come to an emergency department for acute, unplanned or emergency kind of a surgery. So again, in case of emergency surgery, the surgery has to be done, but the important thing is that you stop the NOACS and you again, reversal of the NOACS is very important by the reversal agents. Unless you reverse these agents, you cannot go ahead with the acute emergency surgery, or you need to defer these surgeries if it is not a very urgent procedure. Then you need to defer such patients for 24 hours at least to wean off the effects of oral anticoagulants. And again, so what do you do when a patient needs an elective intervention? So we wait for 24 hours preferably for such patients for the effect to wean off. And after the surgery, when you need to start, because these patients in the post-op period would also be at a very high risk of stroke. So you again have to start these oral anticoagulants at the earliest. And because of the surgery, the risk of bleeding is there, the other risk factors are there which predispose the patient to bleeding, and patient is often elderly patients and are having antiplatelet drugs also, which also increase the risk of bleeding. So in these patients, you preferably start the NOACS after 48 hours if it's a low bleeding risk. And if it's a high bleeding risk, you wait for another 24 hours, which means after 72 hours, you can start these NOACS. So depending upon the various categories, to summarize, dabigatran is a very good drug for prevention of stroke in such patients, and the dose is 150 milligram twice daily. Patients who have bleeding tendencies or have previous history of bleeds, then there are two options: a lower dose of dabigatran under 10 milligram twice daily, or apixaban in full doses can be given in such patients. Patients who are having GI bleeding and need to be on oral coagulants, then apixaban is the drug of choice. And if a patient has compliance problems, then the best drug would be rivaroxaban, because this is a OD drug in contrast to both other agents which need to be given twice daily. And elderly patients more than 80 years of age with renal dysfunction, the best drug again is apixaban with lower doses, 2.5 milligram twice daily. So another important topic, that if a patient is taking vitamin K antagonist or warfarin, how do you switch on to different agents? So if a patient is taking VKA or vitamin K antagonist and we need to give oral anticoagulant in such patients, then you stop the NOAC can be started immediately if the INR is less than 2. So the first thing is that you do the INR. If the INR is less than 2, you can immediately start NOAC. If the INR is between 2 to 2.5, you can start NOAC either immediately or you can wait for a day for the INR to come to less than 2. And if INR is more than 3, then you need to wait till the INR comes to less than 2. And you need to again do INR after 2 or 3 days and serially monitor these patients for the INR and start NOAC when the INR comes to less than 2. And if a patient is taking NOAC and you, for some reason, you need to switch it over to VKA, or maybe cost reasons or whatever reasons, then how can you switch it to vitamin K antagonist? So in such patients, you need to continue NOAC because NOAC is already taking. You need to continue NOAC for some period of time, and then again you do the INR. And when INR comes to less than 2, that is the time when you can start vitamin K antagonist and keep on monitoring the INR levels every third day so that the doses of warfarin or VK can be titrated. Another important topic, everybody has used NOACS in COVID pandemic, and NOACS have been quite beneficial because of the thrombotic milieu in the COVID situation. And so many people or patients must be asking you also when they have to get the vaccines, what is the precautions, what are the precautions they take? So if a patient is on NOAC, then the morning dose of NOAC is not to be taken prior to intramuscular injection. We need to use a fine gauge needle for injection. Thirdly, after the injection or after the vaccine, you need to give some firm pressure for 2 to 5 minutes so that there is no formation of hematoma. And when you restart it after the injection, so in OD NOACS, which is OD is in case of rivaroxaban if a patient is taking, then you can start rivaroxaban. If you have left out the morning dose, then you can start it in the on the next day. And in case it is a BD NOAC, then you can start on the next schedule, means you can start the next dose in the night. And this is the checklist of patients which you always need to follow up with such patients on NOACS. Every time on each visit, you need to ask the adherence, whether patient is taking all these medicines or not. You need to investigate the patient for thromboembolism. There's history of thromboembolism. Is there a history of bleed? Every time, all side effects of NOACS have to be taken into account. Additional medicines like antiplatelets, the drug regulation, or non-steroidal anti-inflammatory drugs patient is taking or not. And needless to say, the renal functions or hepatic functions need to be taken into account. And these are the dosing errors. If a patient has missed a dose or taken a double dose, if he doesn't know whether he has taken any dose, some elderly patient might be forgetting. How do you deal with it? So, thank you, ladies and gentlemen. I hope I've been able to do justification with the topic, and we can discuss as per your.
Such a nice talk, dear, and I wish that the talk would have been a little lesser and more time for our interaction, because everyone here is a super master. So I'll set the ball rolling. Just clear my doubt. In your presentation, you had said for how long to give DAPT and anticoagulant, various indications from 1 week to 2 months and all that, and then step down. So when we step down, what is the last leg? You told it was anticoagulant. Is it anticoagulant when you are taking only aspirin? So please clear my doubt.
Yeah. So the thing is that in acute coronary syndrome or elective PCI in a patient of NOAC, in the first 1 week or first 1 month, depending upon whether he is elective PCI or acute coronary syndrome, you need to give triple therapy. After first 1 month or first 1 week, for next 6 months to 12 months, then you have to switch over to dual therapy, which means that oral anticoagulant has to be given and either aspirin or clopidogrel has to be given. And after that, the aspirin can also stop, and after 12 months, you only need to give oral anticoagulant therapy in such patients who are having atrial fibrillation.
Right. So it is basically for atrial fibrillation.
Only atrial fibrillation.
Yeah.
It
if
is,
one
it
has
is
no
for stroke prevention.
Yeah.
It is for stroke prevention.
If there is no atrial fibrillation, then
obviously
it's not
then it is not required. Then the oral anticoagulants are not required, and
so
only
you are
aspirin after
basically
12.
sticking to your
Right.
So just a few small questions. How does the chance of stroke differ in a valvular and non-valvular AF?
So in all the trials they included, they excluded these patients of moderate to severe mitral stenosis and mechanical heart valves. So all patients, the risk of stroke has to be calculated, and the risk of stroke will depend upon so many factors. So that is why, as a generalized, they have done the CHADS-VASc score, and the risk of score has to be calculated individually on that CHADS-VASc score. And if the CHADS-VASc score is significant, then you need to add oral anticoagulant.
So my point was, is the chance of stroke more in a valvular heart disease or a non-valvular AF? AF is both sides.
It doesn't matter, sir.
AF
It doesn't matter.
Both.
Right. It doesn't matter.
If one is having valvular or non-valvular AF, the chances of stroke are almost equal.
They are almost equal, barring additional risk factors. So what additional risk factors are there? They increase the chances of stroke.
Right. So it was interesting to know that hypertension and age,
right,
they are
very important risk factors.
CHADS-VASc and has blood also. Right. So you very rightly told in different conditions which one to be used, and apixaban was having an edge from others in case of CKD, and for compliance the rivaroxaban was one which was good. Just tell me one last, my question is about a person who is pregnant and having AF. So what is your choice?
So in pregnancy, the NOACS are not indicated, sir.
All right. And does it have...
the trials have shown that they are not indicated, and the unfractionated heparin needs to be given in such patients.
So do any anticoagulant interfere with the menstrual flow?
No, they cause generalized bleeding, but as far as menses are concerned, that is a total different scenario.
It won't affect the flow.
So these agents do not increase the menstrual flow.
So I am now opening up the forum to my friends. Dr. Tulsi is very anxious to ask first question.
Okay, Dr. Dhall, that was a very lucid talk on NOACS. Can we say DOACS? Because DOACS is the preferable name according to the International Society of Thrombosis and Hemostasis. So, would you say is the present NOACS or DOACS are the ideal anticoagulants, or do we have scope for better anticoagulants or better NOACS?
So I think as of now, they are doing quite a good job because they have predictable mode of action. You don't require monitoring in such patients, and the chances of bleeding is far less as compared to warfarin. In warfarin, you need to titrate the doses depending upon the INR, and more so in our COVID situations, each one of us doesn't need to see the patient, doesn't need to monitor INR, and straight away give NOACS if they are indicated in such patients. So I feel NOACS are quite good, but of course, time is going to tell. There's always a scope for better.
Right. So, are you concerned as far as the interaction with the drugs are concerned? Because it was, a burning topic just a few days back, maybe 2 days back, COVID drugs and rather anti-COVID drugs and NOACS. So, tell us a little interaction, Are you worried about the drug-to-drug interaction? Why I'm saying is because we know that certain drugs like antiarrhythmics, like amiodarone, verapamil, digoxin, and such like drugs, and diltiazem, then statins, atorvastatin, lovastatin, macrolides, ARTs, and antifungals do react.
Yeah, so there are extremely important drug interactions with these, and the doses of NOACS need to be regulated. But more importantly, these NOACS either decrease the efficacy of other drugs, or there is slight decrease in the efficacy of NOACS when these drugs are given. But when these drugs need to be given, they have to be given because they do more good than harm, in the sense that the stroke prevention in atrial fibrillation is our primary aim. Now, if you are giving some drug and that drug has some effect on NOACS, we just cannot decrease the doses of NOACS because the side effects of those drugs will not come. But if a patient suffers from suffers from stroke because of decreasing the NOACS, then we are going to do more harm than good. So it is extremely important that these drugs have to be given, barring those indications of elderly patients, renal dysfunction, hepatic dysfunction, then, but drug-to-drug interactions definitely are there, but they are at a lesser as compared to warfarin. In warfarin, we need to worry about much.
So no continuous monitoring needed, but specific clinical scenarios may necessitate coagulation testing such as hepatic and renal functions or impairments, suspected overdose, serious bleedings or thrombotic events, and emergency perioperative management as well. What do you say, sir? So when you do this, let me complete, sir. So when you do this, probably in dabigatran, we do a TT, which is a thrombin time, and ECT, which is a carotid clotting time. So they are sensitive markers enough to, probably measure the anticoagulant activity of the drugs. What do you say, sir?
Right. So in majority of the scenarios, the levels of drugs don't need to be taken because we take it for granted that the patient needs these drugs and we have to give. But in certain situations, as you have mentioned, an emergency surgery is to be done. A patient is taking NOAC. Now, if you do the emergency surgery on NOAC, he is sure to bleed and he will die more of bleeding rather than by the, say, appendicectomy or any life-threatening situation. The bleeding complication will make him die. So these are the situations, or if he's having acute stroke, then you need to, these pre-op situations, emergency situations, as you rightly said, pointed out, these situations, they warrant. But unfortunately, in our country, as of now, we don't have much assays to assess these levels of these drugs, or they may be available at very few places. So that's the pity of the situation, that you need to do this, but unfortunately you can't do these. And some patients do go ahead with surgeries, and the results can be guarded in such patients.
Right. My last two questions would be, you referred, to a 2018 study regarding IV alteplase in patients who are on NOACS. So the guidelines, the previous guidelines were recommending against the use of, IV alteplase. But recently, as recent as February 10th, in the Journal of American Medical Association, they said it is absolutely safe to give IV alteplase even on patients on NOACS. There is no perceived risk of increased intracranial hemorrhage. In fact, the outcomes would be better. What do you say?
Right. So that's what I'm saying, that the guidelines keep on changing. The guidelines keep on changing, and we have to weigh the risk of stroke versus the risk of bleeding. In case we feel that's a clinical individualized decision. So guidelines give us a sense of a direction. But individualize, we have to see and individualize each and every case. If the risk of bleeding per se, we feel that will be more in a patient who's an elderly patient, more than 75 years of age, the risk of bleeding is more. He's taking NOACS, he must be on some antiplatelet. Then I think, this is my personal opinion, guidelines would just guide you, but giving thrombolysis in such patients might do more harm than good. So in such patients, I think it is individual decision, and a clinician has to see all the scenarios, the background, the check factors and all, and then decide whether these things need to be given or not. Because you are obviously adding to the bleeding value by giving IV ritaplase or tenecteplase.
Right. So last question regarding COVID-19 and the NOACS or the ROACS. So January 2022, this year, current guidelines from the American College of Chest Physicians and the International Society on Thrombosis and Hemostasis suggest that all hospitalized patients of COVID-19 thromboprophylaxis with low molecular weight heparin only, and not to give NOACS or DOACS in patients as Antiviral drugs like remdesivir are substrate of CYP4A pathway. Dexamethasone also is a, you see, of CYP4 pathway. So, and the effects remains for more than a week. So, NOACS and NOACS have no role at all. What do you say?
Right, I see. NOACS have been probably misused and used much more than what they were required to during the COVID times.
Yes, absolutely.
So the clear-cut indications are that you use it when there is atrial fibrillation, when you need to prevent stroke. So the baseline indications will remain the same, or there is a high tendency of clotting tendencies where you need to anticoagulate such patients. So you rightly said that NOACS have been probably overused, but I think you would be the best person to enlighten me on that, sir.
So no access in patients.
So sir, here D-dimer
let
is one of the point of the
complete.
Just,
So D-dimer.
I am giving you a food of thought, sir. Just elaborate on D-dimer. D-dimer.
Irrespective of the D-dimer levels, these drugs are not to be given. If any drug has to be given in a moderate or a serious patients, you have to give low molecular heparin. Now the active 4B trial, placebo-controlled RCT evaluated the efficacy of apixaban versus aspirin to prevent thromboembolic events and hospitalizations and reduce mortality in COVID-19 patients. And the trial was stopped because of low event rates and because of its futility. So the drugs probably have a question mark. Now finally, my last question is, Dr. Dhall, regarding, LV thrombus. If you have a LV thrombi, so probably there also no access have not to be given. Probably you would prefer vitamin K antagonist?
Yeah. So there are certain situations where vitamin K antagonists have to be given instead of NOACS. And these situations would be number one, moderate to severe mitral stenosis, prosthetic heart valves, because they have not been tested in the trials. And besides these, there are two more conditions where you need to give vitamin K antagonist. One is, as you rightly said, LV thrombus, and the other is anti-phospholipid antibody syndrome, where the chances of bleeding is far more if you give NOACS as compared to vitamin K antagonist.
Right. So let me conclude my questions by saying that probably Daddy has the lowest risk of interaction with COVID-19 drugs, and apixaban may be the best bet amongst the NOACS for frail elderly patients with atrial fibrillation. Thank you, sir.
Thank you, sir. Thank you.
Dr. Tulsi, just before you leave the forum,
I'm not leaving.
Before you leave the picture, just clear our doubts.
Yes.
That if it is no remdesivir is being given, then still you are afraid of giving NOACS?
Yes, because they said that it really doesn't help. Unless and until you have severe or moderate to severe disease, then only give it. It doesn't help.
So D-dimer is a bullshit?
In fact, a compilation of many studies, recently published guidelines indicate nowhere that the NOACS is considered to be a preferable option. It is sensible to use heparin and heparin alone in patients moderate to severe. In low infection or low risk patients, don't use anything.
I am afraid, sir, after some time you may find a reversal to whatever you have said.
Well, these are the latest January 2022 guidelines from the College of Chest, American College of Chest Physicians.
Sir, what I am saying, what we are following was latest at some time. So that
was about a year back, January 2021.
This may also
2022. We learn every day, Dr. Kalra.
This time shall also pass. Well, we are learning, sir. I am saying that we are never sure that whatever they are saying now will not revert, because everything they have reversed.
Things may change tomorrow. You never know.
They are changing so fast, sir. Please carry on. My friends ask further questions, Dr. Chauhan and Dr. Podar and other curious friends, sir. All open to you.
Dr. Kalra sir, after some wonderful questioning as always from you and Dr. Tulsi sir, I have some questions to ask to Dr. Aseem Dhall sir. So my first question is very, I would say stupid question. Sir, why NOACS only for non-valvular air, not for valvular air, sir?
So,
Sir, I am a very stupid person. I am asking very stupid questions.
So, see, the thing is that it is just the inclusion criteria which they have taken. They have not discarded other valvular lesions. They have included all sorts of valvular lesions. They have taken all sorts of valvular lesions except for severe mitral stenosis and prostatic valves. So if a person has mitral regurgitation and is having atrial fibrillation, those atrial fibrillations are included in all these trials. They have just discarded these because these patients, prostatic heart valves and severe mitral stenosis, they have high incidence of LA thrombus and LV thrombus. And in such patients, testing of these drugs, they feel that these drugs may do more harm and has more bleeding history as bleeding tendencies as compared to the other units. That is why they have excluded. But all patients, valvular patients, are included in these. So if a patient has aortic stenosis and has atrial fibrillation, the same hold goods for these patients as well.
Right, sir. Sir, now you mentioned about a situation of ACS where we use dual antiplatelets, and you also mentioned if this patient develops AF, then what should be the way forward? So my question is very simple. In an ICU setting, you would prefer a low molecular weight heparin in an ACS setting. Am I correct?
Right.
Right. Okay. Now, if I give this patient dual antiplatelet plus low molecular weight heparin, once you discharge this patient, how do you plan giving him NOACS, sir? Suppose this patient has got a LV thrombus, sir.
No. The thing is that if you are treating such patients conservatively.
Okay, let me specify the question. My question is a question of extensive anti-AVAL MI, whom we have stented.
Primary PCI has been done.
Primary PCI has been done. This patient is on ticagrelor and aspirin, and this patient is also on low molecular weight heparin because of a LV thrombus, which is not a situation very uncommon. We see it at times. Sir, how do you solve this dilemma? Kindly tell us.
So, see, if a patient is having anterior wall MI with the primary PCI has been done, so the guidelines say that you have to start the low molecular weight heparin is not to be started in such patients. Okay. Once you have done PCI, then triple antiplatelet, triple drug therapy has to be given. 2 antiplatelets and 1 oral anticoagulant. Those have to be given.
Which oral any of the three?
Either of them. Yes, any of these three can be given.
Depending upon the renal function.
Depending upon the comorbidities and renal function, you can give any of these three. And all right, sir. Low molecular weight heparin is not indicated in such patients when you do PCI. Because if you give low molecular weight heparin and you have to add oral anticoagulant is to be given instead of low molecular weight heparin, because the oral drugs can be taken as an outpatient department also in such patients. So those need to be continued.
Right, sir. Sir, we understand, and you although did not allude this into your talk, the only NOAC for which we have an antidote is dabigatran. Am I correct, sir?
Right, but the others also have antidote. Adnexalate alpha has been the drug which has come up, although it is not very much available in our country. But still, that for dabigatran it is adarucizumab, and for the other ones, the common drug is adnexalate.
Right, sir. Sir, for your patients in Indian Spinal Injury Center, which is the NOAC that you often use you tell us, sir, what is your preferential choice? If the
So
kidney
as I
function
told,
is alright.
see, as I told that we are using the NOACS. Most commonly I am using apixaban, but
And what is the dose that you use?
dose is very clear. Dose apixaban to 5.5 milligram twice daily. Except
5
the
milligram.
only indication in which you have to use lower doses is one, if a patient has previous history of a major bleed, and he has a tendency to bleed, and secondly, if he has severe renal dysfunction, which is the creatinine clearance less than 30, then you are in these only two circumstances, 2.5 milligram twice daily needs to be given. Otherwise, in all the cases, it is 5 milligram twice daily, and there's no point giving doses less than this.
Right, sir. Sir, some of my physician friends who are in practice, they would be wondering if you start a NOAC for a no valvular AF, is it for life?
NOACS have to be continued for life, barring any untoward events which happen during follow-up. They have to be given so long as you want them to prevent stroke, because the stroke prevention, the only aim for starting NOACS is stroke prevention.
Sir, in one of the meetings that I attended on NOACS, very good question that came up was, sir, we always cover these patients with dual antiplatelets, with strong dual antiplatelets like aspirin and ticagrelor. What is the additional benefit if you add a NOACS, sir? What is the trial and what is the evidence?
No, you mean in PCI patients or what?
Yes, sir. We are talking about PCI patients specifically, sir.
Yeah. So in PCI patients, the advantage of adding the thing is that ticagrelor is often not given as a triple therapy, but of late in some circumstances ticagrelor has been added. So the conventional antiplatelets which need to be given with oral anticoagulants are aspirin and clopidogrel. Because ticagrelor is highly potent and much more potent than clopidogrel, the chances of bleeding tendencies were far more if ticagrelor was included in the triple drug regimen as compared to clopidogrel, which was included in this triple drug regimen. So oral anticoagulant plus aspirin plus ticagrelor, the bleeding chances would be more in contrast to oral anticoagulant plus aspirin plus clopidogrel. That's number one. And number two, ticagrelor of late has been used in some cases where the chances of a stent thrombosis is more, where the lesions are more complex, they are highly tortuous, where we have used multiple stents, because in those cases we don't want the stent thrombosis or any cardiac event to occur, right? So we use more potent ticagrelor as compared to clopidogrel. But in other cases, the clopidogrel is the one which is used.
Sir, I will ask you a personal question now.
Sir,
You must have been using NOACS for a long time now. You are no stranger to the use of NOACS, right from the days of dabigatran. Sir, I want to ask you some straight questions. Kindly answer them in yes or no. Are NOACS better than vitamin K antagonist?
yes,
The conventional vitamin K antagonist?
yes.
Right. Number two, sir. Are the NOACS without any side effects?
No, they have side effects in the form of bleeding. So you have to look for bleeding tendencies. You have to look for renal deterioration in such patients. They are very important. You have to look for thromboembolic events in such patients. You have to look for hepatic functions. So they are not, because they have, some NOACS have renal excretion, some NOACS have hepatic excretion. So patients of renal dysfunction or hepatic dysfunction are the ones which deteriorate very rapidly on these drugs. So you have to repeatedly keep on monitoring such things. But the INR need not be monitored. That the monitoring means the INR need not be monitored, but other parameters need to be monitored at regular intervals.
Right, sir. Sir, I want to also know, you also said that NOACS would need some remodeling, maybe some modifications in the future to come. And Dr. Tulsi asked that question specifically, can we see something better emerging? And you said they are the best thing that we have right now. Sir, suppose a patient with NOAC, apart from dabigatran, for which we have an antidote, and you mentioned the other one for which I don't think the antidote is available in India. I don't know.
It's not, right.
For the other ones, the antidote is not available. And I think the fresh frozen plasma is the best thing, the next best thing to get back to. Now, my last question, sir, to you is, how often do you see the need for these things with NOACS? I mean the bleeding with NOACS. So you said they are not very innocent, and do not think that they are just very good alternatives to vitamin K antagonists without any side effects. You said there is a very genuine risk of bleeding. How often do you encounter that risk, sir, in your center?
So in general, you see, ours is both orthopedic center and a very active neurological center also. Besides that, after I joined in, now it has become an active cardiac unit also. So
I have witnessed that. I have witnessed
right.
that early in the morning at 4 a.m. At 4 a.m. myself.
Right, sir. I remember that patient, a friend of a mother of your friend from UK.
Yes, and sir is logged in right now. Dr. Sanjay Nanchal is logged in right now.
Oh, that's great, sir. That's great. So the thing is that such patients, neurological patients, do come in with history of acute stroke, but majority of these patients I have found were not on NOACS. They were not taking NOACS because NOACS are still underused for this indication of atrial fibrillation or prevention of atrial fibrillation. We are not giving these drugs for the fear of bleeding. So as the cases increase, as we keep on using these NOACS more often, we will definitely encounter patients, elderly patients, who will be coming with bleeds subsequently. As of now, because of underuse, we are not seeing much patients.
Great learning from you, Dr. Aseem Dhall. Honestly, I have always believed that you are one of the best in the trade. Although you shy away from projecting yourself, it was my endeavor to project you to the forum.
I am extremely grateful for that, sir. I am extremely grateful, sir.
As one very, very serious in the business. Although I can have a word for you, if you do not mind, as an elder brother to you.